Hello. Welcome to Kindly Neurodivergent with Kay. This show is to spend quality time with each other, kindly discussing the similarities and wide range of differences we experience. The experiences we discuss on this show are for educational purposes only. Please do not substitute for professional medical advice, diagnosis, or treatment. Before we begin, I respectfully request that if you witness any pauses during this show, please don't stop watching. I'm composing a spontaneous comment or question. The guest can choose not to say anything while this is occurring. This is natural discourse when an augmentative and alternative communication device user is communicating with a non-augmentative and alternative communication device user. In lieu of Better Speech and Hearing Month, I have a former speech-language pathologist of mine, Marci Silver, and now one of my many bosses, as I'm her office manager in charge of emails, marketing, reviewing documents, etc., to discuss what her field covers. Marci Silver is the president owner of Silver Speech, currently in New York, California and Connecticut, certified private speech-language feeding pathologist for both children and adults. Marci also started a Silver Speech speaking series during COVID-19, interviewing previous clients who live with communication differences and other professionals who contribute to the field of speech-language pathology. Furthermore, she added another series co-hosting with me called The Inside Scoop of Living with Cerebral Palsy, interviewing other humans who live with cerebral palsy and other professionals who contribute to cerebral palsy. She also appeared on guest interviews with dentists and pediatricians on their podcasts. Welcome, Marci.
Hi, Kayla. I'm so excited to be here.
Please introduce yourself.
Hi, everybody. I am Marci Silver, a speech-language pathologist here in New York City. I also do work in California and Connecticut, like Kayla said. I am super grateful for this opportunity. Kayla was a previous student of mine when I first started out, and we've kept in touch over the years. And now she works for me and she's my friend. So we have a lot going on. We are constantly in contact every day. She texts me, I text her. We laugh, we cry. And she puts up with my numerous corrections that I send her. And she always is excited that I'm challenging her. And I'm so happy and impressed that you started your own show.
Even though I have been in speech for most of my life, I only understand speech-language pathology from a feeding and communication perspective. The muscles we learn for feeding are the muscles we learn for speaking too. When I was younger, speech-language pathologists helped me in finding ways to communicate functionally my needs, wants, and social greetings. They helped convey to other people that I understand everything and research the appropriate means to share my knowledge and ideas via communication to use in a variety of settings. They taught me feeding techniques to help me strengthen and shape my muscles to safely chew, swallow, and say words that would be clear to my listeners. You have hearing loss yourself. Tell us about that.
Well, thanks, Kayla, for asking. Yeah, this is sort of a more recent diagnosis. I, about 7 years ago, got diagnosed with Crohn's disease. which is an autoimmune condition. And I was put on some pretty heavy medication called Humira, which is a biologic. And you inject yourself with it. I pretty immediately my body did not react well to the medication. And sure enough, I went from hearing perfectly fine to a moderate to severe sensory neural hearing loss. So I really haven't gotten my hearing back. I had contacted Sloan Kettering, who has vitamins, and I contacted the pharmacist who's used to this, and he gave me some vitamins to try to regenerate my hearing, and it was not successful. So I have hearing aids, which I am not good about wearing. So that's, I have to practice what I preach. However, I am able to relate so much more to my clients who have hearing loss because other sounds that I can hear are actually so much louder. And then the sounds that I can't hear, like low frequency sounds, male voices, it's very hard for me to understand on the phone. I also background noise, restaurants are extremely loud for me, so it's hard for me to go out to dinner with more than 4 people. And I do recognize hearing loss in children so much more now because I experience some of the same things that they do, and I actually have similar behaviors to them as well, such as looking away to make sure my hearing is closer to the speaker. Um, my hands can go over my ears when something's really loud. And I just have to remove myself from situations because it's taxing on my brain to listen for a very long period of time.
Must make work interesting.
Yeah, it really does because I have to focus more on hearing the children and their speech difficulties. I sometimes have to ask them to repeat it. I record information so I can play it again. So the strategies that I teach my clients are actually the strategies that I use in my practice. So it's easier to model for my clients what I do that helps, but not always does it help all clients. So it totally depends. I always give people options.
Let's talk about a few general things. What is speech language pathology?
Excellent question, Kayla. As you can see, I'm actually doing a lot of pausing too in when I'm speaking. I'm not jumping into the conversation right away. And I love what you said about the pausing, because that's a really excellent communication strategy to get people to listen to you when you pause and you speak slowly. So speech language pathology, I basically look at different speech parameters. So I look at a child's or adult's oral motor structure. So their jaw, their tongue, their lips, their cheeks. Are they moving appropriately? And is the structure appropriate? So I look at jaw stability. I look at dental structure. I look at their tongue. Is it hanging out of their mouth? Is it at the roof of their mouth? I look at their precision of their articulators. So are they moving their muscles in an efficient and effective way? I look at, can they lip protrude for sh, ch, and j? Can they lip retract for s and z, t, and d? Are they raising their tongue for L, or is their tongue sitting in a neutral position where it's L? And then I look at Also, I look at jaw position for vowels. So that's oral motor. I listen to their loudness level. Do they speak loud or soft or at just right volume? I look at fluency, which is the pace of their speech. Is it way too fast where they're talking really fast? Or are they talking slow? Or are they talking at a just right speed? I also look at intonation. Do they speak with surprise? Or do they speak monotone like this? Or are they speaking in a very high-pitched voice? Or do they speak in a low voice? So I look at their pitch. I also listen for their resonance. Do they sound like they have a cold when they're speaking and only breathing through their mouth? Is their mouth open at rest? I'm also listening to hear if there's nasal emission coming from their nose. And then I look at their articulation. I look at how are they saying sounds in each position of a word. So do they have a cut in the beginning? Do they have a cut at the end of the word? Do they have a cut in the middle of the word? And it's all the phonemes that they say in each language. So I look at that. I look at the syllable level, the word level, the phrase level, the conversational level. So that's speech. And then I also look at their language, receptive language, that's what they understand. So can they follow directions? Do they follow one, two, and multi-step directions? Do they understand basic concepts like in, on, under, over? And do they answer questions accurately? So do they answer what questions, where questions, who questions, why questions with an accurate response? So that's receptive language. And then I look at expressive language. So that looks at their form, their content, and their use of language. So I look at form is their morphology and their grammar. Do they have plurals? Do they have past tense? Do they have future tense? Do they use prepositions, pronouns, possessives? And then I look at their use of language, so their pragmatics. Are they maintaining topic of conversation? Are they initiating conversation? Are they making eye contact? And then I also look at their semantics, like what kind of vocabulary are they using? Are they using nouns, verbs, adjectives? So that's expressive language. And then sometimes I look at reading comprehension, I look at writing skills, we look at phonological awareness, spelling when they get older. So we see a whole range, and then we look at feeding skills too. So I forget that I am a feeding therapist as well. So just like Kayla said, that the muscles we learn for eating are the muscles we learn for speaking. So I'm always observing people when they eat. Do they stick their tongue out when they're eating? So this is called a tongue thrust, where they're coming towards the food. I'm looking at, are they biting and chewing on the sides of their mouth? Bite and pull, which pulls these muscles and works these cheeks so that they can say E, oi, T, and D. So we need to use our jaw muscles, our molar muscles to move our cheeks. And then I look at the sensory piece of feeding. A lot of people have sensory aversions to feeding. So I look at their sensory system. Are they leaving food on their face and not feeling the food? Are they hypersensitive to food? They don't like to be touched. They want it wiped down right after they eat. So that is the gist of speech language feeding pathology.
What is the difference between executive functioning and cognitive therapy?
Wow, Kayla, throwing me curveballs. Okay, so executive functioning skills is a form of cognitive therapy. Okay, so it's a part of cognitive therapy. So executive functioning, we look at executive functioning as attention, different types of attention. So undivided attention, divided attention. Um, we look at, can you multitask? Can you focus on one task and listen to another task? Are you able to wait before touching something? Um, are you able to follow directions over and over again, or do you make the same mistake over and over again? So that's the difference. Cognition and cognitive therapy, executive functioning is under cognition.
How do you work on attention?
So attention is very important. We need oxygen to the brain in order to attend. So our lips need to be closed, our tongue needs to be at the roof of our mouth to really have attention. If a child doesn't have attention, we can't work on speech and language skills. We first need to achieve attention. So, we work on it in very different ways depending on the child or the adult's needs. We work on, using the mirror to attend to themselves first, and then we take them out of themselves, and we work on, attending to play. So at first, someone who has really poor attention, we're going to work just on simple play tasks to get them to attend and play with certain play tasks. And then we obviously expand that. So it totally depends on the level of attention. I always say, 1 year, 1 minute, 2 years, 2 to 3 minutes, so again, there are age appropriate minutes for attention, or what a norm or an average that we look for and then try to help children achieve or adults achieve.
How does sensory affect what you do?
So our sensory system is a huge factor in everything we do as speech language pathologists, because we have to touch the child. We have to touch their face. We have to give them support from their back to have them sit up straight. We have to do prompt on their face. So tactile touch is a sense. So if they're tactile defensive, or they don't feel you when you touch them, they have low muscle tone, that's going to impact their sensory system. Also, if you're not breathing through your nose, and you could have enlarged adenoids, you could have enlarged tonsils, that's a sense you've lost, or it's blocked. If you have hearing loss, hearing is a sense. So if you're not hearing, then you have another sense that's not working. And so your ears, your nose, and your mouth are all interconnected. So if two are blocked, you're going to have trouble integrating your senses throughout your body. And that's why we call that, sensory integration or sensory processing disability or delay. Well, we say delay or disorder, or we say differences now.
How do you do it with blind?
Well, that's an excellent question. So what's beautiful is that there are schools specifically designed for, American School for the Deaf. There's School for the Blind. So, it totally depends on the child. If they're blind, they learn Braille. And that, is a specialty in itself. It's a whole degree in working with the blind. But, as a speech therapist, because it's a sensory need, if the child can see, depending on, their sight restrictions, we make things bigger, or they might get distracted by, 3 pictures, so we only do 2 pictures. Or they might get overstimulated by 2 pictures, so I just have 1 picture. So, we rely on vision experts for the visually impaired or the visually challenged.
Talk about how posture affects your work.
Wow, Kayla, you keep throwing these questions at me, and I have to really, really think about these things. So, form follows function. So if we don't have postural control, we are going to have trouble with walking, crawling. So first comes gross motor and fine motor. So we're learning to sit up, and then we're learning to crawl, and then we're learning to stand up, and then we're learning to walk. And then we also sit in a chair to eat. So if a child isn't able to sit up at 4 to 6 months to eat solid food, they're not ready yet. They have to be able to sit up so that they can chew and swallow and, have good feeding skills. So you need postural support. So the number one importance for eating is breathing. So we need number 1, breathing, number 2, postural support, and then number 3, that's when we can eat solid foods. So those 3 in order is really important. So postural support is also very important for speaking. So if we don't have postural support, we can't babble, reciprocal babble, and then produce sounds.
What is the difference between feeding and oral motor?
Wow. This late at night, you're throwing me all of these questions. Okay. So we need oral motor. So feeding is a skill. It's a learned skill. So from 0 to 4 months, it is innate and natural, and it's it's not learned behavior. As soon as you introduce solid foods, that's a learned behavior. So if you don't have the oral motor strength and the oral motor structures in place, you're going to have difficulty eating and feeding. So oral motor is a huge part of feeding. So it's a part of feeding. Even for bottle feeding. So if, we're seeing a very big, I get a lot of kids that are 4 to 6 months when they start to have solid food or having difficulty. And it turns out that they are still low tone in the core. And we also look at tongue tie. So we're seeing a lot of tongue tie and lip ties. So children are having an increase in eating difficulties. And when you have a low core trunk, because you're not, doing enough tummy time, or you're not, rolling over from side to side, you're not strengthening those muscles, when it's time to sit up, you're going to have some reflux too. So we're seeing an increase in babies that have reflux as well. So reflux, tongue is a very important part of eating. The tongue needs to be resting on the palate to eat. And with tongue tie, we're seeing our tongues down like this. And then we need our tongues to lateralize to bite and pull the food. So oral motor is a huge skill in feeding.
I still don't like tummy time.
You still don't.
I still don't like tummy time.
Oh, yeah, I could see that. It's uncomfortable. Yeah.
My meal times are complicated because I am at a high risk of aspiration. I have to take small bites and sips, make sure that food is on my teeth and not stuck on the roof of my mouth. Due to all these safety precautions, it literally takes me 1 hour to eat every meal. I gulp down protein shakes and milkshakes much faster.
Yeah, I could see that.
How do you help stutters and clutters?
So, stuttering and cluttering is a specialty in speech language pathology. There's a lot of therapists that actually decide to not a lot of therapists, but there are therapists that specialize specifically in stuttering. Now, I have I've gotten a lot more stuttering clients recently due to many different things, including sleep disordered breathing, enlarged adenoids. I'm seeing a lot of kids stuttering because they're not nasal breathing. And when we speak upon exhalation. So we breathe in and then we breathe out and we speak. So I'm definitely seeing a lot more stutterers, but I get from the ages of 2 to 5, stuttering is considered developmental. And then once stuttering occurs after 5, it's usually going to last their lifetime. So it's a very, and it's 4 to 1 for 4 to 1 boys to girls. Um, and it totally depends. Sometimes, so I do therapy from 2 to 5 to train the parents. A lot of the training for children, little, is training the adults, training the teachers, training the adults on how to communicate better with their child. Um, whether it's environment, so slowing down their environment, not rushing them out the door for preschool, giving them time. Also, more relaxing, quiet activities, reading books, letting them play by themselves with no speaking involved, letting them initiate the conversation, not forcing them to say hello when we know they can say hello. They don't need to be forced to say hello. We also work on pacing with the parents. So instead of jumping into a conversation after the child finishes answering the question, you count to 3. You wait and then you ask another question. Or if the child asks you a question, you count to 3 and then you respond. So again, Kayla mentioned pausing in the beginning of this series, and it's so important to pause. And for stuttering, for sure, very important, is giving them time to listen to themselves. So you don't want to interrupt them when they're stuttering. You let them stutter it out, you let them clutter it out, and then you respond to them. So there's a whole protocol that we follow, and it's, a lot of it's modeling. And then if I feel like the child needs a more specialized approach, that's when I refer out.
What surgeries may require your services during recovery?
Um, I mean, there's like a wide range. I would say, most of my clients get um tonsillectomy, myringotomy, adenoidectomy. Those are the ones that I see, and tongue tie release. So those are the surgeries that I have most experience with. But people that work with adults more, they're gonna see sometimes we see swallowing patients that have had neck surgery, or laryngectomy patients that have their larynx removed and they have a prosthesis. So we see surgery too, or they've had a traumatic brain injury and they've had brain surgery, or they've had brain cancer, and so we're giving them therapy. So we see a lot of you know, different clients with different needs and different surgeries.
How do you assist other parts of language like morphology, syntax, semantics, pragmatics, and phonology?
Wow, that's a loaded question. That's a lot of information. Um, so language it totally depends on the child. It depends on the age. Um, and it totally depends on the age. So at first, when a child isn't speaking and they're 2 years old and the parents are saying they're not speaking, we really simplify our language for them. We speak at 1 to 2 words, because they're at a 1 word level. So we really simplify. We say in, car, up, above, take out. So we're narrating for the child. As they get older, some of their syntax and morphology, they might be leaving out plurals or tenses, or they might not have possessives. So then we really bombard them with those goals. From a pragmatic standpoint, we work on, just pretty much it's really practical. I mean, I'm a practical therapist, so I live in New York, so we might go to the diner and order some food and have a conversation. We might, how do we initiate a conversation? So it's more natural. Social language is um, a natural therapy, and also it's social skills aren't rule governed, so it's really hard sometimes to do therapy without you know yeah, it's hard because sometimes the whole social interaction gets interrupted by someone who's trying to make a rule. Um so that's the social language. Writing is super important. I mean, I know Kayla and we do a lot of work together. And sometimes, she has great questions about, her syntax, her morphology, or the way she writes sentences. And it's improved significantly since we've been working together, but over the years. Um, so tell me, Kayla, what are your, um, do you have challenges with writing?
I am always debating because in the nonverbal world, one word equals one sentence.
Yeah, that's a good point. Yeah, I mean, you had asked me that a while back. And two, you're an AAC user. So yeah, pictures, you use pictures a lot more, or like one picture might have two words on it, like I want. So it's a challenge. But I feel like your writing has improved significantly since you've gone to college and you have to write papers. Um, and sometimes, when I edit your work, I could see where it could be like a run-on sentence because you don't know when it's supposed to be a pause or when it's supposed to be a comma or a period. But that's improved significantly just from the practice that you do with your writing.
For example, I still only say bathroom, please.
Right. And then there's sign language. So you have sign language, you're an AAC user, and then you're writing college papers, right? So it's very different. But this world is not writing anymore. We are going back to hieroglyphics where we are now sending emojis. So, we don't write like we used to, which is changing, and which is, writing is becoming more acceptable, short form, which I'm a linguist and I love to write, so I'm not particularly happy about it, but that's the way our world works now with text message, abbreviations.
I have to be professional.
Yes, exactly. Um, and it's interesting because, then there are appropriate abbreviations. Like when I worked in the hospital, you write abbreviations for things in the charts that all medical professionals identify. So we are short forming things so that it's quick when a doctor needs to read something or a therapist needs to read something, we know exactly what they're talking about.
Why is learning to write difficult after you learn to speak? I would think that it would be similar until you get to an essay length.
Well, that's a good question. I think that what we hear is translated onto paper. So there are also rules that you need to learn, um, but you have to have a good ear for sounds too. So it is complicated because you also have to learn the the gross motor, because you have to have good postural support for writing. So you also need excellent fine motor skills to write. And then you actually write sounds, letters, words. Now, you have to be able to draw a straight line, then a circle, then an X or a cross. So that's why writing is so complicated, because it requires gross motor, fine motor, hearing, speech, and then the whole writing. And there you go.
How did English become so complex all around?
Well, Kayla, that is because English is not like the other languages. There's always exceptions to the rule. And there's British English, and then there's, American English too. There's standard American English, there's African American vernacular. There's all these different, there's code switching between languages. So language is complicated. Language changes over time. So English has changed so much. Um, you know, it's interesting when you read old textbooks. or old literature. The way you read it is not the way you speak it now. So, language is constantly evolving. That's why it's so complicated.
How do you help bilingual students?
So, I usually recommend a bilingual therapist if they're available. Usually, if a child is delayed in their first language, they're going to be delayed in the second language that they learn. So it's really important for them to get treatment in their primary language. It's also very important. I see a lot of this in New York City, is that they're being raised by their caretaker or their babysitter or their nanny who speaks broken English. So I always recommend that they speak their language to that child because they're getting the just right language model. It's very important for them to get that. I have kids that speak like, they themselves speak broken English. So it's really, really important that they speak, they can hear different languages and they'll pick up on them and they'll have the appropriate language to use.
Is English my primary language, or is it called something else?
Yeah, no, English would be your primary language, or sign language too could be your primary language because you learned sign before you learned to speak. So, yeah, but English is your primary. Your spoken language, right? So sign language is a gesture language. But that's an excellent question. I might not know the answer to that. That might have been the wrong response. Incorrect. I'll actually have you research that for me.
I feel like it is complicated.
Yep, put it on your to-do list. Find out. Let's see.
Please discuss alternative and augmented communication.
What? How about you describe your alternative and AAC for me?
I was immediately labeled nonverbal. The speech therapist introduced sign language to jumpstart my expressive communication. It was determined that finger spelling was easier physically for me and more universal to teach others. I later learned how to communicate with the world through an augmentative and alternative communication device. To match me with a reliable voice, I had an AAC evaluation. This assessment helped my team determine methods, devices, techniques, symbols, and/or strategies to represent and/or augment my spoken and/or written language. Initially, I had a communication device called Dynavox. It had pre-programmed grids filled with picture vocabulary, buttons to formulate sentences together, and a keyboard with word prediction. Perfect, right? No. While it taught me the value of technology, voice-activated communication, and more diversity in my vocabulary, I experienced a lot of intense feelings towards my big, bulky, and expensive Dynavox. My biggest complaint was that it constantly kept freezing, especially when I had something important to say. Many repairs were constantly necessary for this dinosaur, And let's definitely not underestimate the stress without a concrete visual audio system in place. In high school, it was suggested that I bring in my 9.4-inch iPad. Lo and behold, I finally found a reliable communication application called Proloquo2Go. I actually prefer not to utilize the pre-programmed grids that automatically are provided on Proloquo2Go. I find that it is too limiting and reminds me of the dinosaur I had. However, I take advantage of pre-programming my own thoughts for any presentations, interviews, and/or conversations I participate in. After graduation, I had another AAC evaluation where I switched to the device that I still have now, a 12.9-inch iPad Pro.
Yeah, I mean, you have come so far with that. I mean, I saw you when you were 3 years old. And actually, we were just talking about this today, that I was I was right out of school. I didn't have a lot of experience, but it was eye-opening for me to kind of research about AAC. I took an AAC course in college, or grad school, but we did go to crack and try different devices out, and different augmentative and alternative devices. They had like just come out with, a microphone that wrote for you. You would say something and it would write it out for you. It was like early stages. And then the Dynavox was really the one of the only devices available at that time, but it's come so far. And again, I refer out for an AAC devices too, because that's not my forte. So you're very knowledgeable in what, and usually it's the student or the patient that is able to tell us what works, what doesn't. Um, and you're quick on yours.
Since everyone uses nonverbal communication like body language, why do you think sign language isn't universally taught in schools and daycares?
Well, I think body language is different than sign language. Body language is basically emotions. It's just emotions, right? So if I'm turning my head and not paying attention, that's body language. If I'm rolling my eyes, that's body language saying like I'm not interested. Or if you move closer to somebody, that shows you're interested. So body language is very different than sign language. Sign language is a means of communicating other things. But yeah, I think it is an important tool for sure. Um, and they do offer courses at school in sign language and educational type programs. I know that they offered that at Teachers College.
When and how do you know if the concept of matching object to picture or picture to picture is something for speech therapy rather than language arts, or practice with someone you know, especially if this is the very first step of communication?
I mean, a lot of ABA therapists use object to object first, and then it goes object to picture, and then it goes picture to picture. So, there's a whole hierarchy for that. And that, is a form of communication that is super helpful for especially nonverbal speakers. So you have to train them to identify the objects first, um, and then match the objects, and then match the object to the picture so that they can use the picture to get the object. And then, like now you just use pictures to communicate, which then makes sentences and words now. Now you use your own thoughts. So it's a whole hierarchy on communication.
How does play relate to speech language pathology?
So play, when we look at play, it's very easy to see where a child is in their language development as well. So for example, there's different levels of play. There's parallel play, there's associative play, there's cooperative play. So there's different levels of play, and within those different levels of play, the language development comes in. So when kids are parallel playing, they're not using questions necessarily because they're just modeling each other's behaviors, but they're making sentences, right? They're commenting on their play. Um, they're using actions for their play. They're developing sentence structure, but then when they become in a more cooperative way and turn-taking way, then they're asking questions, they're answering questions, they're commenting, um, they're curious. So we use play as a way of assessing language development and where they are.
Since nobody is perfect, how do you judge if a child just needs extra social skills, reading and or writing practice in a bunch of different ways, homework, audiobooks, a family or educator sitting down with them reviewing something, just time, etc., or needs to receive speech language pathology?
Wow. Lots to that question. We usually use um criteria. So there's mild, moderate, significant delays or disorders. Um, and sometimes we might see um need for more input or some strategies we give families if we don't think they need it. COVID really changed a lot of a lot of things. And so we are seeing children that need more language, social groups, and learning how to play again. And we also see with the masks. So we've seen an uptick in speech language referrals. Um, but I think that, like we said, everybody needs to work on something. We all have our strengths, we all have our areas of improvement, we all have our glows, we all have our grows. Um, so it's really important to know that, I think it's up to the parent too. Like sometimes parents will just be like, "Oh, I want you to work on this because I notice that sometimes I can't understand them or they shy away or so it totally depends." But, also school systems and insurance companies are very different than, getting some extra help. So early intervention, they set a criteria, so you have to be negative 2.5 standard deviations from the mean of the testing to qualify in 2 areas. Or the board of ed, they have their own criteria where it's like, oh, they just have speech but it's not impacting their education, so we can't give you the services. So that's when parents might get the wrong idea too, because they're like, oh, they said that they didn't qualify, so they're fine. And I get that a lot, but it's only because it's a funded program. So they only accept, they've made a rule where it has to be 2.5 standard deviations from the mean to qualify for the service.
Is
So
it
there is that gray area.
is okay? Is it hard for you to determine what is okay?
It can be sometimes, but I always use my clinical judgment. We look at environment, we look at, are they a second sibling? Are they a third sibling? Is there a lot of kids in the family? We look at the makeup of the classroom. So sometimes they have mixed age groups. Oh, this child's the youngest in the classroom, this child's the oldest. So there's so many factors we use to determine services.
Please talk about public speaking skills.
Yeah, so I see adults with and also kids with public speaking. So we work on presentations. Sometimes I work on accent modification where people come from different countries and they work for these big companies and um the company says, "Oh, can you improve your English production? So when you're presenting, we can understand you better." So, I have worked with different people from all over the world. For instance, I worked with an accountant who was from China. And so, I'm very practical. So we work on her presentation and the words that are involved in her presentation so that she can practice those words and practice the motor movements involved in the sound. And then she does present that to me, and I work on, was it loud enough? Were you looking at the audience? Were you pausing? Did you just run off the stage without getting questions? And I see a lot of progress with that and improvements. And some people aren't even aware that they do that. Um, so those are some of the public speaking skills that I work on, both on a Zoom call or a WebEx conference and in person. So we do both.
How do you assist with accent modification?
Um, So basically, it's the same as an articulation assessment. Basically, I have them read um, label pictures for me, and they look at each sound in each position. But the difference is I need to know from each what language they speak and what sounds are typical in each language. So, for instance, Asian languages, Japanese, Chinese, L and R are very difficult for them. So we work on L and R. TH is a difficult sound. And then, an Indian language, they do a lot of voicing in their speech. So they don't have voiceless and voiced cognates. So those are some examples of what I would do to help them.
Thank you, Marci, for doing this with me. It was great to have you on. Please share this talk show with your family, friends, clients, and colleagues. Everyone watching, don't forget to like, follow, subscribe, and share on Facebook, Instagram, and YouTube.